Hello, everyone. Good morning, good afternoon, good evening, wherever you may be in the world. Welcome to day 6, the final day of our CCIH 2021 virtual conference focused on health system strengthening. I'm Mona Bormett, Program Director at CCIH, and we are so glad you could join us for the conference. We look forward, of course, to being able to meet together in person again soon. But until then, we are very grateful to have this technology to bring us together now. You will see a slide with all the days of our conference, and soon you'll see a slide with the instructions in French and Spanish to join the language interpretation channels. So if you need that, we hope you utilize that, or if you want to practice your language skills, you're welcome to join those channels. Today, we will hold all the questions until the end of the program, which will be at approximately 9:40 US Eastern Time, before we then transition into the networking and breakout rooms. We will collect questions until then. So feel free to use your chat box to introduce yourself, tell us where you're joining from, who you are, and also as speakers, say something that interests you or you have a follow-up question, please put that in the chat box. We have staff who are monitoring that. And we are also super grateful for all of our sponsors who have helped make the conference possible. Our platinum sponsor today is Abbott. We've had many sponsors throughout the conference, and we're just so grateful to all of them. And we're also grateful to all of our speakers and moderators who've prepared. Today's moderator for our session on health system strengthening is Rick Santos, who is President and CEO of Church World Service. Prior to that position, he was board chair of the Joint Learning Initiative on Faith in Local Communities, also known as JLI. And from 2009 to 2018, he was president and CEO of IMA World Health. And in his 9 years there, he led the organization through a period of rapid growth that included increasing program impact and building healthy communities in some of the most difficult places in the world. Rick also led a merger with Lutheran World Relief and stayed on as senior advisor through 2019. I've had so many great, wonderful conversations with Rick throughout the years. I'm so grateful for his mentorship and his down-to-earth conversational style with so many folks in so many different countries that I've been fortunate to be in meetings and conferences with Rick. I'm also very grateful that Rick is a member of the CCIH board. So welcome to Rick, and thank you again for moderating today's session. So over to Rick.
Thank you, Mona. It's great to see you. Thank you for the kind words, and welcome everyone to the last day of this year's CCIH conference. Many of you know, and if you're new to CCIH, we are an international network of nearly 120 Christian organizations and 15 secular partners, as well as a few hundred individual members, most of whom are based outside the US. CCIH's mission is to promote health and wholeness from a Christian perspective, and we provide opportunities for capacity building, networking, sharing best practices, and advocacy. So some logistics for today. This session is being recorded, and it will be posted to the CCIH YouTube channel and a conference playlist, and you will find links to the recordings on the CCIH website at www.ccih.org under events. So as we move in today's topic of conference, it's unity and health system strengthening. I think having a focus on health system strengthening is a really great way to round off the week, or round off all the conference sessions. You know, the 6 pillars that WHO has identified include information, financing, service delivery, leadership and governance, human resources, and medicine, vaccines, and technology. So as we think about health system strengthening, we think about what does that mean to have 6 pillars, and how do they all work? And frankly, I don't think of them as pillars. I think of them actually more as something like a Rubik's Cube, where you have all these you have the pillars, but you also have multiple cross-cutting themes, and how you emphasize, where you put priority, where you have resources, and how that all works together is more complicated actually than a Rubik's Cube. So as we have dealt with kind of the idea or the issue and the concept of health system strengthening this past year during the pandemic, we've really seen our health systems be stretched. We've seen our health systems really go through, in different countries, incredible challenges, both here in the US, where I'm from, and across the globe. And most recently, I think the headlines were in India, that the ability of the health system to address and to respond has really been challenged this year. So I'm excited about our session today. We're going to be talking about vaccines. We're going to be talking about some technology. We're going to be having other pieces around health systems discussed. So really welcome to today. And as we go into the different pieces, please put your questions in the chat box, and we're going to take questions at the very end. So first I'm going to begin, and I'm going to introduce Stuart Knight. Stuart is actually from Abbott, and who is our platinum sponsor. I'm not going to read his whole bio for you. I'm just going to give you a couple of highlights. The first is that Stuart is the head of global accounts for the Abbott Rapid Diagnostics Division. And Stuart has, which is wonderful for this, I think, session and to hear, has a real passion for facilitating equitable access to high quality point of care diagnostics and treatments for infectious and neglected tropical diseases across low and middle income countries. And I think there couldn't be a better topic as we are getting through this pandemic for us today. So welcome, Stuart.
Thank you very much for that introduction. Hi again, Stuart Knight from Abbott Rapid Diagnostics, greeting you from the Washington, D.C. area. So pleased to be part of this program. Abbott has been a proud sponsor of this program now for 2 years, and looking forward to many years to come. Many of the partner organizations that are on this call today are current customers and current consumers of Abbott products. We are working in about 148 countries across low and middle income regions, and are key partners in the fight against HIV, malaria, tuberculosis, hepatitis, and of course, COVID. Abbott continues to make investments that brings point of care diagnostics to the most vulnerable patient populations. This is so critical for patient retention, where patients may be traveling for hours to get to a medical facility. So being able to provide them with a diagnosis of some of these very critical diseases within 15 minutes or certainly on the spot, and giving them access to treatments and treatment strategies immediately is so important for these patient populations that don't have the luxury of access to care in every environment that they live in. Abbott continues to make investments in disease areas that frankly have no viable commercial market. And we do this gladly and do this for the sake of patients globally. So looking forward to working with this network of organizations. So proud to be part of this intersection of faith and medicine, and looking forward to advancing care for the benefit of patients we all serve. Thank you.
Wonderful. Thank you, Stuart. That was very helpful. Abbott's done a lot of work in the developing world and in low and middle income countries, and we appreciate and thank you and commend that great work that you do. So I'm going to transition over to our very first speaker. It is Dr. Thabani Maposa. And Dr. Maposa and I had a chance to speak prior to the conference, and it was really a wonderful conversation. And I'm really excited about this session today. And so just a little bit about his background. Again, I'm not going to read the whole background that's on the slide, but just some highlights for me. He's currently the Managing Director of Country Programs for Gavi, the Vaccine Alliance, where he oversees Gavi's operations in 73 countries. The country's program department goal is to save the maximum number of lives through immunization. And again, in this moment of pandemic and COVID, I think that's a really important area for Gavi and for the world. Prior to joining Gavi, Dr. Maposa was World Vision. He was at World Vision for over 16 years. And he also worked in academia as a lecturer and in physiology and microbiology. So we'd like to welcome Dr. Maposa.
Thank you very much for the warm welcome, Rick, and it is a pleasure to be here with you today.
So wonderful. We're going to do a small question and answer period, and so without further ado, let's begin. So before we go into the kind of the heart of the conversation, Dr. Maposa, I want to know a little bit more about you, and could you tell for the people who are listening today a little bit about your faith journey and how that led you to your current work?
Thank you very much. My faith journey probably begins at a small village in Luakwelu. That's what it was called in Zimbabwe. That's my birth village. And really, the seeds of my faith, I would say that they have come from my grandparents. And one of the most important things and gifts that my grandparents left for me was the love for music. And when I think about my Christian journey, it is always associated with a song in my heart. And so the question that I always say to my children is, what song do you have this morning in your heart? And for me, for a very long time, the song that has been in my heart is On Higher Ground, which is, I think some may know this song. I've never had a great voice in terms of singing. And so that's why I speak about a song in the heart, because I sing it from the heart. And not very well, but it goes a bit like this. I'm pressing on the upward ground, new heights I'm gaining every day. Anyway, I will not be messing up with the ears of your audience today by attempting any singing that I don't have a gift of. But the truth is, that's where part of my journey begins. And then it is obviously reinforced by a wonderful verse that says, to whom much has been given, much is to be expected. And for me, when I think about that verse, I think about it in an expansive way. I have seen the goodness of the Lord in the world of the living. And I have been in situations where I have suffered from bilharzia, I have suffered from measles, I have seen children lost in my own community because of measles, and the gift of life on an everyday basis really represents that element of gratitude in terms of to whom much has been given, much is to be expected. But we are given in a number of ways. And in whatever I do, the desire is to always say that, how can I thank the Lord for this much that has been given to me? So that's an element of my faith journey given in a condensed form. I am a grateful soul. I am a joyful soul with some music in my heart, who believes much has been given to me. And indeed, much is expected of me and those around me.
Thank you, Dr. Maposa. That was very lovely, and thank you for sharing that song. I share your gift for not being able to sing, but I appreciate the comment of the song in your heart. So let's move on to some questions and some reflections on on the role of vaccines. So I'd love you to just outline your view of how the role that vaccines play in health system strengthening.
Thank you very much. You know, in public health, vaccines have been called the best buy. And the reason for that is that they are one of the health interventions that really reaches far and wide. And because of that, they present an amazing opportunity of being a pathfinder for a primary health care system. And they get to places where other health interventions may not always be able to reach. And so they may be the first ones. But then the biggest question here is that when they've been the first ones, when you think about the communities that we serve and the places that we work, immunization is important, but for the communities that really are in the hard to reach places, it's much more than immunization that is important. And so how do we use vaccines as an entry point? Because they do represent the first contact point with some patients and with communities. And so how do we make sure that that first contact is not wasted in terms of experience, what I would call the patient experience, so that they are able to come back to the healthcare system. If the vaccination does not work well, it doesn't bode well for the rest of the health system, because if this is the first point of contact that anyone has, then it means that the risk of them not trusting the system is higher. So the way the service is delivered in the first place is extremely important. But the recognition that the service in itself is a start and not the end, and it must crowd in other health investment, and it must come as a set of blanket interventions, becomes quite important. So I call it a pathfinder of healthcare, but definitely not the end of healthcare.
Wonderful. Thank you, Dr. Maposa. So, you know, when we talk about vaccines and we talk about health system strengthening, often people think about governments, they think about multilateral organizations, they think about big hospitals. What they don't think about is faith-based organizations, civil society organizations. So from your perspective, what do you see the role of FBOs and CSOs in vaccinations and health system strengthening?
Thank you so much for that question. And when I think about vaccines, we have a mantra and we say it's called the 3 V's. And these V's, where they come together, is an important point. The first V is obviously the vaccine itself, which has to be coming through the supply chain and the cold chain, as we all know it, the hard nuts and bolts element of it. But the second V is the vaccinator. And in terms of the vaccinator, here we are talking about the frontline health worker that is actually key and very important. And then the last piece is the vaccinee. The vaccinee may be the child or the adult who actually needs to get the vaccine, that needs to come to get the vaccine. As the story goes here, you can take a horse to the drinking point, but you can't force it to drink. And the faith-based community, where I have seen it being extremely important, it is important, by the way, in all the V's that I spoke about. But one area where it is really much stronger than anybody and has a unique positioning is actually in the demand space, which is the demand for the service for vaccination, the identification of those populations that may have been missed, the ability to reach those populations as well. We have at Gavi what we call the Ema Framework. And the Ema Framework is about identifying communities. When it comes to identifying, nobody does it better than the FPOs because they are much closer to the communities. Then when it comes to reaching as well, there is nobody who actually reaches some of those hard to reach places as well as this community does. Then, of course, as part of that, there is also the monitor and measure elements, which the FPOs and the rest of the civil society play. But then there is the advocacy role, which is advocating to reach communities that may be marginalized and may be excluded. These are roles that the FPO community have played very well and will continue to play. And we see that as significant, especially in the time of COVID. It's a role that this community can bring to bear even more.
Wonderful. Thank you for that. That's very, very helpful. So this is a related question because, you know, there was a lot of fanfare around the COVAX initiative and the COVAX initiative being different from previous initiatives. And so as we look at that, and again, when I first read about COVAX, I saw the private sector, there was some civil society and other players involved in that, but I wanted to understand from your perspective, what role do you see now FBOs and CSOs playing in that COVAX initiative?
Sure. I think you have asked me the question, and I'll ask it in my own words. And if I were to reframe the question you have asked me, is what keeps me awake at night right now? And I will tell you that there are two things that are keeping me awake at night. The first one is the supply of vaccines. We have seen and we have watched the uneven supply of vaccines. And this is an equity issue. At the heart of it, it is about equity and whether equity is true. And the success of COVAX really sits at whether we will bring equity to actually be able to deliver. And so every day when equity is missed is a day that I go to sleep with a broken heart because I am wondering whether we are fighting a losing battle or we still need to put up a fight the other day. And so on the supply space, I would say that the FPO CSO community really needs to help us with advocating for equitable distribution of vaccines. For those countries that have access of vaccines to be able to share with the rest of the world. And this goes back to the fundamentals of the question you asked me at the beginning. What drives my faith belief? It is to whom much has been given, much is to be expected. Whether it is about technology or it is about wealth. When you don't use what you have been given for common human good, the God that we serve does not sit pleased with that. Our God is a God that says, I will bless you as you bless others. So for those that have been blessed, what role are they playing in this particular situation? The hoarding that we have seen is not helping what we are being called to be in this world. Then the second issue that is keeping me awake is what I call the absorptive capacity of countries. You would have heard stories in recent days of countries that have received vaccines and they have actually had some of those vaccines wasted and not used. It is a sad situation to be in a place where the world is actually dealing with scarcity of vaccines, as I just pointed out on the supply side. And then we have a situation where in some other part of the world, vaccines are going to waste because they have expired in some hands of a government or in some hands of someone somewhere. So all this is not acceptable. It does not bode well for our efforts to end this pandemic. So the civil society, the FBOs have a role to help us with the vaccine hesitancy and demand issues that are happening at a country level. But they also have a role in the upstream level to actually advocate that those countries that have excess doses, they donate them and they share them with those that need them. So it's a two-pronged approach, advocating at a global level side on the supply side, but also advocating at the country level side as far as the hesitancy issue is concerned, and making sure that the vaccines are used whenever they hit the ground.
Thank you. So I'm going to just do a quick add-on to that. Really wonderful response. So those are two critical pieces, I think, for the role of CSOs and FBOs. But what about service delivery? I mean, is there a role for CSOs and FBOs in the delivery of vaccinations? Indeed.
Of course, I'm speaking as someone who's slightly sensitive of not abusing the privilege of your time. But, you know, we have a number of windows that we have created at Gavi. One of them is called the humanitarian buffer. The humanitarian buffer is a set of vaccines that have been set aside for those situations where governments are not able to reach, but civil society and FBOs are able to reach. In places like Syria, in places like Yemen, you know, and in places like northern Nigeria, and part of the Sahel, and part of the East Africa where there is conflict. So there is many places where the civil society can contribute to that. But we also are going to be releasing a substantive set of resources around demand generation, because that is going to be an important area as well.
Well, thank you. And so as we look at a year of the pandemic, more than a year now, you know, how do you view the impact of what's happened because of COVID on health system strengthening more writ large?
Well, I think COVID has put a spotlight on our health systems, and it has shown how much they can carry. And I think that it is safe to say that if we have seen health systems struggling in the developed world, it must tell us a story about in the developing world. I think we have a lot of work to do that is in front of us. But one of the biggest things here in the health system space that maybe is extremely important to think about is the surveillance work and the power of anticipating. How do we make sure that we are better prepared in the future? I think this pandemic may be the first for this generation, but it will not be the last. And when you combine this with the climate change related dynamics, I think we are in a dress rehearsal. Something bigger is going to come our way, and we need to be seriously prepared. And if our response is what we have given at this particular point, we will not be able to withstand what is coming our way. I think our response as a collective, as a society, has been less than optimal. And we need to be prepared that if something bigger is coming, and it surely is, we should be taking a cue and key lessons from here.
Wonderful. So yeah, I mean, I think, yeah, key lessons I think is critical. Your comment about how we are probably in for something bigger, and it's not just how we responded this time, but what we learned from our response this time, and then how we've adjusted and adapted ourselves. So Dr. Maposa, I'm going to try to squeeze in one quick last question. I just want you to think about what would you say is your challenge to the faith community today in light of all that we've talked about? And it needs to be a quick answer because we're almost out of time.
Indeed, and I already partially answered this question. Yes. The supply and demand issues are the issues that are urgent right now. And you can speak to the supply issue through your advocacy. You can help on the demand side through helping with social mobilization. You have a role to play, and we need you, and we need you now.
Wonderful. So thank you, Dr. Dr. Maposa. I'm so grateful for your time this morning. I know how busy you are, and also it's different time zone in Geneva. Just appreciate all that you've said, and I look forward to talking to you more in the future. So thank you again.
Thank you very much, and thank you for the platform and for the audience.
My pleasure. So I'm going to move on now to our next speaker. In the vein of multilateral organizations, we are going to be talking with Sarah Hess. Sarah is, again, I'm not going to read her bio completely, but I'm going to just do some highlights. So Sarah is a public health expert working in health emergency program at the World Health Organization in Geneva. Sarah, actually, my wife works for PAHO WHO, so I know the organization quite well. And just a few things about you and your work. Your current role is within the risk communication and community engagement pillar of the COVID-19 response. So I think a lot of the things we've just been talking about with Dr. Maposa, I think are relevant. You lead the faith engagement and initiatives for youth and empowerment and private sector engagement for health. So welcome, and looking forward to hear your remarks.
Thank you very much, Rick, for the kind introduction, and thank you very much for the opportunity to be here today. It really is a pleasure. So I think much of what I have to say actually reiterates or echoes some of the conversation that we've just heard today. I'm going to talk just a little bit about what WHO is trying to do to support the role and work of faith actors in the COVID-19 response. So next slide, please. I mean, I think it's clear, Rick, as you mentioned, and Tabani too, that the pandemic has exposed really significant gaps in health systems around the world, not just in low and middle income countries, but in high income countries too. And I think it's become very apparent that we need a whole of society approach to strengthening these systems and responding to the current pandemic, and then of course preparing for the next issues that might arise. And I'm really glad that Tabani brought up that the need for preparedness and getting ready for the next one, because we're very clear that there will be subsequent health events. And so WHO really acknowledges the integral and impactful role that faith actors play in emergency preparedness and response. I think faith-based health service provision really directly supports the national health system. And this is, we have seen as really important when health systems are stretched in times of crisis, such as the COVID-19 pandemic. But in addition to this direct health service provision, there are multiple ways in which faith actors increase community resilience and keep communities healthy and well and out of an already stretched health system. And so a lot of these actions that promote resilience and social cohesion are critically important in times of crisis. We're also really aware, here I am sitting in Geneva operating at a global level, but for many faith actors, they're deeply embedded within communities on the ground, providing social support and psychosocial support as well, advocating for marginalized or vulnerable people. And so really what WHO is trying to do more and more now is to support this role of faith actors in emergency response. So please, may I have the next slide? So what we've done at WHO here at the global level is we've identified 3 areas of work that we feel we could work alongside faith actors on to support this response work. And we've convened 3 multi-faith communities of practice with different representatives from different entities and faith groups. And the 3 communities of practice are working on these different areas of work. The first is really around communication. As has been mentioned by Tabani, there is a lot of hesitancy around the COVID-19 vaccines. And we see faith partners as trusted voices that could really bring messages to their communities based on the scientific evidence. And so we're really trying to work with faith partners to support this communication around the vaccine. The second area of work is to develop a WHO strategy for engaging faith partners. And this is to kind of further institutionalize this work and partnership and collaboration. Sorry about that. I hope you can hear me again. I just noticed that I was muted quickly. So just to say that the second area of work that we're looking at is developing the strategy, and that was to really look at how WHO, faith actors and governments can work together in health emergencies and support each other in this role. The third area of work is looking at some interesting research needs, training and capacity building. And these are areas of work that might be critical to furthering the work of faith actors. And so next slide, please. These 3 communities of practice are going to work together on these areas of work, and they're going to feed into a virtual conference that we hope to hold in the 3rd quarter of this year. And you can see, I'm not going to go into a lot of detail, but it's I've put on this slide a little bit about what this work is going to cover in the virtual conference. I've mentioned before that collaboration in health emergencies. We want to really try and showcase how collaboration has happened at a national level between ministries of health, WHO, and faith-based organizations. And a lot of these examples and models are going to feed into that strategy document that I talked about. We also are going to look at spiritual care during times of crisis, and the objective of this theme is to really highlight the role and impact of faith partners in how they provide spiritual care during crisis. And this includes things like chaplaincy and pastoral care. Again, another critical role that faith partners are playing in emergencies. And then the third, a very interesting one, an important one, looking at how past histories of medical racism are impacting vaccine hesitancy today, acknowledging them, understanding them, and then moving on to see how faith leaders around the world are reaching out to promote vaccine confidence. And so we look forward to working with all our faith partners on these important subjects in the build up to the virtual conference. And of course, it's a very open forum, so we do welcome collaboration. Next slide, please. This is a little bit of a repeat again of what Tabani said, but we see faith partners playing a really critical role in vaccine advocacy and equity. Not just, I mentioned a little bit about the communication, so addressing concerns, myths and rumors among their communities, but we also see very practical ways that faith partners are helping and supporting the vaccine delivery. I think we've seen many cathedrals in the United Kingdom converted into vaccine centers. We've also seen around the world a lot of single faith and interfaith statements around equity and access, and these are important advocacy tools. And then many faith partners are spearheading campaigns as well. And this is something that WHO is very much in support of, and trying to amplify these voices as much as we can. And so that's just a little bit about what we're doing at WHO, and I'm going to stop here now, but I look forward to taking some of the questions later on, and really it's been a pleasure to be here today to share just a little bit about what we're doing. So back over to you, Rick.
Thank you, Sarah. Thank you so much for that presentation. I have to say, I've been working in the faith-based health world for a very long time, and that was one of the best presentations around this idea of partnering with faith communities. I feel sometimes the multilateral world looks at the faith world as a way to get something done, to instrumentalize who they are. And what I appreciated about your presentation is you really looked at it from partnership approach, but also from helping the faith community do what they're already doing and doing it better. So thank you so much for your presentation today. We're going to transition to our next presentation. We have actually Myal Greene from World Relief. So again, his bio is on the slide. I'm not going to read all of it. I'm just going to highlight a few pieces. He'll be sharing about the role of the churches in vaccine distribution. So we're building on this theme from this morning, learning from past campaigns as we look to equitable COVID-19 vaccine distribution. Myal serves as World Relief's Senior Vice President for International Programs, and he has a deep desire to see churches around the world equipped, empowered, and engaged to meet the needs of vulnerable families and their communities. So really a wonderful build-up from all the conversations we've been having today. So Myal, welcome.
Thank you very much, Rick. It's great to be with everybody today. As I begin my presentation, I do want to acknowledge my colleague, Charles Franzine, who was really instrumental in preparing a lot of the research behind this presentation, and had hoped to be the one to present to the group today, but was unable to do it. But I'm very excited to talk about the role of the church and the way the church is really strategic and instrumental in vaccination campaigns historically and at a community level. So if you want to kick it off a little bit, we can talk about some of the historic foundations with the next slide, please. And what's interesting is that from the very beginning of this idea and of vaccinations and the first vaccinations that came to be, church leaders are right in the heart and the center of promoting them. And so everybody obviously gives Edward Jenner great credit for the first smallpox vaccine, but what some people may not know is that there was a neighbor of his just a few miles down the road, Reverend Roland Hill in the UK, who came to know about the vaccine very early on and became, he was a known evangelist in his community, but he also became a known evangelist for the vaccine. And if you go back and look at the notes and the history of these long speeches, very much in the format of a religious sermon he would give, it's very interesting to see and distinguish between, in the very early days of him talking about the biblical imperative for becoming vaccinated, promoting these things. And so we see that even in the very rudimentary early vaccination efforts and things like that that took place prior to Jenner's smallpox vaccine, you see reference and evidence to Cotton Mather promoting vaccination and early techniques of vaccination, even, which is interesting, was very controversial in his time and had instances of having things thrown at him because of his promotion of the idea of a vaccination. So it's very interesting that it was the church leaders using their voice to address culturally controversial topics at the time. And then, of course, my colleague Charles as well highlights that the vaccination campaigns really helped wipe out in Scandinavia very early on as one of the first examples of a successful vaccination campaign, and the church was instrumental in those efforts as well. So next slide, please. And so what I think is also interesting to think about and consider is that in the international missions movement, the very early days, we all know that churches were really instrumental in creating schools, health centers, and the like. And with that came the rise and the increase in the availability of vaccines. And so the churches were in many rural communities throughout Africa and other parts of the world, some of the first promoting, utilizing vaccinations in large campaigns and large efforts. And once history in Africa transitioned to formation of stronger health systems, national health systems, and things like that, we consistently see church leaders playing a critical role in those vaccination campaigns. Next slide, please. And so as we kind of move into this space of, kind of a post-colonial era, it also coincides with the rise of many new vaccinations and peace, vaccinations for different diseases and ailments that were available. And so what you oftentimes see is that with some of the newer health systems and things like that, the collaboration between NGOs, the health system, and faith leaders have really been a critical part in leading these campaigns. Doing some research, one of the things that Charles identified is that there's really a common theme theologically that was promoted in many of these vaccination campaigns around the idea of when one part of the body suffers, we all suffer, and when one part is honored, the other part rejoices. And it's this idea that the vaccination campaign as a community activity was really about not just individual health and individual wellness, but the idea of the importance to do this as a whole and as a body, really all committing itself to be healed and be restored, and the benefits for everyone being vaccinated. Next slide. So, we see some interesting theological foundations for this, some interesting historical issues for this, but vaccines are oftentimes a obstacle for people, and we know, and some of my colleagues before me have spoken about some of these specific obstacles we're facing in the community. And what's interesting, some of these are addressing unestablished kind of medical myths or unestablished medical understanding, and then others are related to trust issues with outside forces. And so you see concern from people related to family planning and fertility, which are big issues in traditional cultures and things like that. And we wouldn't want to do anything that affected infertility. Also there's the, now kind of dismissed concerns about the relationship between vaccines and autism, but still those concerns connect and are there. And similarly, I think there's many issues related to distrust of Western society that are at the heart of this. And so whether it's the idea of the Western governments trying to control populations in other countries, or fears about people perhaps being the laboratory subjects and research subjects, which unfortunately, given medical history around the world, are to some degree grounded concerns, not in this case of this vaccine by any means, but certainly concerns that are based off of historic issues and pieces there. And so, we've seen this in other places as well with, a view by people as well that when you've got Ebola receiving a vaccine and COVID-19 receiving a vaccine very quickly, but the HIV, which has been around and devastating for generations now, it does not have a vaccine. And so there's this view of trust of, are all these money-making campaigns, are these the Western agencies using us to raise money? And so these are all real fears that people see, and I'm just touching on a few of them here. And if we go to the next slide, one thing that is very interesting is that, we see local churches and the local faith-based community being very, very prevalent in society. And so some research that Ray Martin and Sambe Duale did in 2014 for part of this conference really highlighted just the example in DRC that 35% of the health districts there are faith-based in nature, connected to both Protestant or Catholic churches. And so really the work of the church is integrally connected to faith, and it's a central part of the health system that exists in many places. And so they play a really critical role. Here's the last part of that. It says, these churches sponsored groups transport vaccines, train health workers, provide vaccinations, and serve as key players in national immunization campaigns. So there's a critical role to be played. If we go to the next slide, one thing that we learned from the Ebola vaccination rollout was that churches were both a really critical tool in advocacy, as well as they were also a risk for negativity in issues here. And so it was really essential from the very beginning to engage the bishops and the church leaders, especially at the senior level, to help engage their faith communities, to keep them, focused on what is right and what is true here, so that the church is not passing on misinformation, but it's also passing on the correct and useful information to promote these. We also realized that on the front line, the faith community was a really essential and key implementer, and being able to engage with the community, model positive behavior, model the importance of getting vaccinations, being witnesses for those, to be vaccinated themselves and promote that. And so this is really a great way for the church as community implementers to be engaged very, very early in the process, and very significantly. So you can go to the next slide. We also know that with similar lessons learned from rollout of ARTs, although it's not a vaccination, it still is an essential medicine that needed to be used in communities. And so again, the church leaders here have played a very significant role in directing attitudes around transparency, but it's also kind of marrying of the importance of connecting technical expertise to the mobilization at the community level, which I think is a very critical thing in any of these campaigns, and I'll talk about that as I close in the next slide or two here. Next slide, please. Is that as we think about how to move forward with the vaccination campaign, equity is going to be one of the central issues here. And I think that there's grounded concerns that the church could be a barrier to equity, but I also believe wholeheartedly that the church is actually a great driver and a key entity in promoting and encouraging equity. And so really where the great opportunity is here, and I love the previous presenter talking about how at the global level, some of the communities of practice have intentionally integrated the faith leaders. And I think at a national level, it's really essential that the planning committees and these things take into account faith leaders from a very significant perspective. The view there. Similarly, it's important that all faith groups are represented. So it's not just Christian churches, even in Christian majority contexts, that we need to recognize other faith groups as being a part of here, and their ability as faith leaders, especially in minority contexts, to be involved in a process there. Similarly, the Christian health associations and the churches should be part of these task force, should be engaged in the media campaign, should be able to use their mechanisms to mobilize community along those lines. And really, again, I think back to this point is that engage in the technical expertise, and the role of the church's ability is also very key. So I think I've got one more slide. And so, yeah, I just want to say thank you. I think, I'll probably just wrap up here because I think I'm close to my time being over, but thank everybody for the thoughts here, and appreciate the chance to speak and talk about really the role that the church can play in a very successful campaign as we think about COVID vaccinations being scaled globally. So thank you.
Thanks, Myal. Appreciate your presentation. I love the history. I know Charles very well and worked with him in the past, so appreciate you conveying his thoughts and remarks, and for your putting your mark on them as well. I think one of the things people don't realize is the history of the church is, oftentimes when the church went places way back when the initial missionaries went out, there were a couple of things they did besides talking about God, and that was building churches and building schools. So there's a huge history and legacy of faith involvement in health over a long period of time. So thank you for that. I'm going to transition. We're actually a little bit ahead of schedule, so great. But we're moving on to the next group. It's actually two speakers, and they're going to be talking about mapping. And so the first introduction is, again, if you see the on your screen, you see a slide. I'm just going to highlight a few things. So Barbara Campbell worked as a registered pharmacist and a clinical nutritionist for about 15 years before her life took a dramatic turn in 2008 when she and her husband heard and received the gospel and began following Jesus. In 2010, she also found herself in Haiti in response to the catastrophic earthquake. So Barbara and I both have the earthquake as a turning point in who we are. Now she is, in 2017, she became the executive director of the Dalton Foundation. Our second speaker today is, so actually let's do that, and then I will introduce the second speaker after Barbara speaks. Thanks, Barbara.
Okay, thank you, Rick, and we're glad to be here. I'm just going to actually share for just a couple of minutes because I want to turn it over to Marie-Claire to share all of what's going on in Haiti. And we greet you this morning from Haiti, and we're praying for this internet connection that so far has been great, and we're really thankful for that. You can go on to the next slide. Just real quick, the Dalton Foundation is a faith-based organization that works both locally in the US around addiction recovery and re-entry support, and internationally a lot with global health. And health system strengthening is definitely our passion. And I'm going to share a little bit about how we approach that. The Relink Global Health umbrella is data collection, because data is really important to us, and it's housed in the relinkglobalhealth.org system. And then the Haiti Health Network, we got to be founding partners of that with some other groups. And it's how we basically operate the work we do in Haiti. So you can go to the next slide. And this is just a little overview of our approach, which is going to tee me up for Marie-Claire to share some practical work. We've been talking a lot about health system strengthening today around COVID and the vaccine. And this is some work that we actually started before COVID. And I'm really happy to say that they were able to literally miraculously keep it going through the political unrest and COVID to start seeing some really incredible results. So if you know me, you know how proud I am of our team. And so we're just going to share some practical work that we've been doing. So one of our first things we always do when we go deep into a country is the mapping work. It's really understanding what's already there. And we've done the work with, in Haiti, we've gathered both demographic data, service data, and then my favorite part, which we're going to share with you a little bit today, is capacity data. So we know where health care facilities are, what services they offer, but we actually try to understand what their actual capacity is to deliver health care on a day in and day out basis. And in a place like Haiti, that can be really challenging. The Relink Global Health Database has two components to it. It has a public-facing piece that shares both the service and the demographic data, and anyone in Haiti can search for orthopedic services or an x-ray machine or whatever the case may be. And then the capacity data we keep for funders, for Ministry of Health, to share our data and our work. So that's a little bit about that. And then our second passion is education and collaboration. We do host at least one webinar a week. Most weeks it's 2 or 3 in Haiti, where we're bringing together healthcare professionals, both US leaders, Haitian leaders, and most importantly, Haitian healthcare providers to collaborate and discuss. So you can imagine in 2020, we were having weekly COVID discussions, and we're still having them twice a month now. It's been really strategic to help get things done and distributed, but also really supportive of all the healthcare professionals on the front lines. And then our third thing we do, which is what we're here to talk about a little bit today, from the mapping and from the collaboration, we sit down and design some strategic projects. And I am going to turn it over to Marie-Claire to spend the rest of our time sharing about one of our projects that we call Equipping the Caregivers. So Rick, if you want to introduce Marie-Claire, we're going to switch seats because we are together here in Haiti.
Yes, so welcome, Marie-Claire. Let me just do a quick introduction. Again, the slide is on the screen. Marie-Claire Charles is the Haiti Country Director for the Dalton Foundation. Born and raised in Haiti, she graduated from Millersville University in Pennsylvania. And in 2014, with a bachelor's degree in international studies. She's also spent some time getting an MBA at Elms College in Massachusetts. So actually, Marie-Claire, you and I both share that. I have an MBA as well. And she also participated in diverse cultural community activities as a student and a young professional, both in Haiti and the United States. So welcome, Marie-Claire.
Thank you, Rick, for this great introduction. I am happy to be here with you today to share some of the work of the Dalton Foundation through the Haiti Health Network in Haiti. And I always say the Dalton Foundation has given me a great opportunity to serve my community and Haiti as a whole, as our work is over the entire country. And as Barbara was mentioning, data mapping is the first thing that we do when we try to identify needs and identify programs for the Dalton Foundation. And we try to understand what already exists, as Barbara says. We try to recognize the challenges to respond to those needs and find ways and the requirements for sustainability, because we want to start something that will last, something that can be replicated throughout the country. And through the data mapping, that really shows us how to go about the programs that we implement in the country. Over the past 2 years, our Haiti-based teams has gone through 9 of the 10 departments of Haiti. So Haiti is divided into 10 different departments: the North, the Northeast, the Northwest, the Plateau Central, Artibonite, West, the South, the Southeast, the NIPS, and the Grand'Anse. The West is the most dense region, and that's where the capital is. Port-au-Prince is located. So out of the 10 departments, the West Department is the one that has where we have not done data collection. And how do we do our data collection? We first get an authorization from the government with the Ministry of Regional Administration of the Ministry of Health. And that's what our team takes to the facilities to show them that we are able to do this work and show what we will be doing with this data and how we are going to use it. And anyone on this call who might know about Haiti, it is difficult to access some of the locations, and we get reports from our team members saying that they have to take all modes of transportation. If they have to go on foot, getting on a donkey, crossing rivers, because the places that are most remote are the ones that we really want to reach to know what the need is in those places. Next slide, please. And some of the data that we collect are the basics. What are the basic medications that you have access to? What are the basic equipment that you have access to? How many patients do you see in a week or in a year? Do you have access to electricity? Do you have access to internet? Who is in your leadership team? And this information, as Barbara mentioned before, some of it we share on the Relink Global Health database for everyone to see. Anyone with internet can see it. And physicians, nurses, facilities, healthcare leaders, they use it too to locate services and to do reference for their patients. And patients too, the people in the community use that data to locate healthcare resources where they can go. And I personally have used that resource for my family for special services around the country. And as you can see, this is just a little bit, next slide, please. And this is just a little bit of the data that we have collected and analyzed that we share here on this presentation. You can see some of the results with equipment. Only about 22% of the facilities in the South Department have access to the basic equipment. And when we say basic equipment, there are things like otoscope, pulse ox, blood pressure monitors, nebulizers, thermometers. And we were surprised to see that so many places don't have access to those equipment. And some of those places don't have a physician at all. They may just have a nurse or a healthcare community provider, a healthcare agent. And those are the places that we try to get this kind of equipment to, so that they can see patients and do the job that they are willing and they're motivated to do. So I'll talk a little bit more about this specific program that Barbara mentioned, the Equipping the Caregiver. And also from this data that we collected, we also have another program called Equipment Modernization and Standardization, and I'll talk a little bit more about those two. So equipping the caregiver, and as I said before, from the data that we collected and seeing that such a great need for the equipment, the crucial tools, we have come up with this program where we distribute medical kits to individual physicians, nurses, and also to the facilities. And in those kits, they have pulse ox, ophthalmoscope, stethoscope, blood pressure monitors, glucose monitors, and so on. And it has been a great experience for me, just contacting those healthcare leaders to let them know that we're coming, and we went to your facility, we went to the entire region, and these are the results that we are seeing, and this is the program that we would like to implement. And the response has always been positive, and one person just said, and I use this as a testimony, for as far as we know that our place is, if you as an organization is able to reach us where we are and bring help, then you are doing a godly work, and may God bless you. And I actually received kisses through the phone because they were so happy. And I always use this story as a success story for the work that we do, and confirming that we are going the right way about it. And we are also open to collaboration, and collaboration is one of our pillars, because we collaborate with local authorities, local organizations, local citizens, to make sure that we do the work efficiently and that we do it the right way. So with the Equipping the Caregiver program, we have done it in 3 of the regions so far, the North, Northwest, and Northeast. And we're planning to do the next one in the South. We call it the Sud Department. And as we continue with the data collection and the data analysis, and as we get more support and as we are able, then we continue to the other regions of Haiti. Next slide, please. Or you can go to the next one. And this is just a picture of the map of Haiti and where we have done the Equipping the Caregiver program. In the North region, we have distributed over 250 kits. And in the Northwest region, we have distributed over 300 kits to physicians, nurses, and the facilities themselves. And we know the number of kits to distribute based on the data that we collected, because we see how many nurses and physicians are in each facility and how many facilities are in that region. And this data, it's an evolving work, because new facilities are opening, some might stop functioning, or new people, new leadership. So we keep direct contact and constant contact with those facilities to make sure that our data is up to date. So next slide, please. And the other program that we have is the equipment modernization and standardization. One other thing that we realized during our research was that the equipment, there's a lot of equipment, donated equipment, and they're all different makes and models. They are broken, no one is available to fix them. And we thought if we have the ability to donate equipment that are the same make, same model, and we have the support to fix them and keep them updated and have somebody on the ground and somebody in the United States who can work together and make sure that those facilities, they are interconnected, they can share the resources, and the equipment can stay working for the patients. Next slide, please. And as we mentioned about collaboration, and Barbara also mentioned about the webinars, the networking that we have, we are able to identify new programs, and the neonatology intensive care modernization is a program that we were able to identify through collaboration, through healthcare providers telling us what the needs are and how to go about them. And next slide, please. And this is a slide just to show how we collaborate with different organizations. Those are not all that we collaborate with. We have a lot more organizations that are not showing here, either through training, through a speaker at webinars or conferences, or just to have them use us as a distribution tool for different programs that are going throughout the country. Thank you so much for your time, and thank you for giving us this opportunity to share about the Dalton Foundation and the work that we do through the Haiti Health Network.
Thank you, Marie-Claire. That was a wonderful presentation. I think such an interesting use of data that you're doing and support for caregivers. I mean, really wonderful. Thank you so much. And also thanks, Barbara. Thank you to Barbara for your presentations today. As we move on to the next part of our morning, I'm going to introduce a gentleman, Paul Apedha, from ADRA. Again, I'm not going to read the entire slide, but Paul is a community health nurse midwife with rich experience and full range of primary health care and management across the project cycle. He has worked in both urban and rural healthcare facilities across Kenya and in complex humanitarian contexts. He also did work with IOM and Ebola treatment in Liberia, and his current position is a health specialist for ADRA Yemen. Just before Paul begins, so a couple of things. One, I want to remind people that you can put questions for all our speakers in the chat box, so please do that. We're going to be doing questions at the very end. And I also want to mention, because of some problems with internet where Paul is, we're going to have a recorded presentation first. Thank you.
Hello, welcome from ADRA Yemen. My name is Paul Apedha. I'm a health specialist with a nurse midwife training background. I am specialized in working in very complex emergency health situations, such as in the Ebola outbreak in West Africa. Now I'm here in southern Yemen. I've been looking forward to CCIH. With this presentation, it is my sincere hope you will go home with a very practical example. ADRA has a large program funded by USAID Bureau of Humanitarian Assistance that includes essential primary health services in several governorates in southern Yemen. Here, ADRA support community health volunteers, and we support primary health facility workers such as medical assistants, midwives, nurses, nutrition workers, and the cleaners. I want to share with you how we are being very deliberate in how we work. We want to ensure that anyone living within one of our many health facility catchments, anyone in contact with any ADRA health facility staff, or any community health volunteer in their community hears one voice and experiences as it one set of hands contributing to fully integrated programming. Come with me as we go to Lahaj Governorate to see how ADRA community health volunteers and health facility workers are speaking in one voice. Behind me is the IDP site in Al Hobeil that is covered within the catchment population for the Al Hobeil health unit that we are supporting, limited curative care and minimum service package for health. Quite a number of beneficiaries are received at the same IDP site, but we still have a long way to go since we are still increasing the capacity of the community health volunteers so that they can be able to serve properly the people living here. Our community health volunteers are an integral part of community health that is a building block for primary health care. We are here at Al Hobeil IDP site. Our CHVs usually conduct home visits to conduct health and nutrition activities, with more emphasis on IPC and standard precautions for COVID-19, health, wash, and nutrition messages that they pass across. This comes screen the children, and for those who need referral, they are referred directly to the health unit. Our community health volunteers are trained to deliver health messages on COVID-19 prevention, signs and symptoms, and referral. Also, they are also trained to take family work with integrated social behavior change messages on wash, health, and nutrition. As you are seeing here right now, she's delivering messages of COVID-19 prevention, showing the mothers with the posters and the other illustrations. The community health volunteer is demonstrating how to give the ORS, how to mix it. She is currently seeing a mother with a child who has had 3 episodes of diarrhea. She will be demonstrating how to give the ORS to the baby to stabilize as she refers the child to the health unit. There is a clear line of link of referral between the community and the health unit with the community health volunteer. With colorful, well-explained posters like this, which can be read by anyone, and the pictures are done so that they can be interpreted easily by the community members, our well-trained community health volunteers deliver the messages to the community members, focusing mostly like this one on COVID-19, standard precautions, how to stop the spread, and how to prevent infections. We are also supporting the facilities that are supporting them with minimum service package, essential primary healthcare medication. We are also supporting with equipment, basic life support equipment to include furniture at the health facility level. While undertaking our routine supervisory visits to the facility, the mother who shared a first bout of diarrhea at the IDP site in Al Hobeil has just arrived at the facility. The medical assistant has screened the baby and cleared the baby according to the IMCI protocols. Temperature has been taken to rule out any fevers as a part of prevention and early detection of COVID-19.
عدد الحالات يوميا للمركز الصحي حوالي 50 مريض.
So how do you think the referrals done by the CHVs from the community to the health facility helping the community?
هو تعامل المتطوعات مع الناس تمام، يعني المتطوعات متواضعات ويعامل الحالات المحالة له المركز الصحي تمام.
I have seen on the health facility wall 6 key messages for social behavior change and COVID-19 prevention messages. Are they the same messages delivered by the community health volunteers at the community level?
يروح المتطوعات للمخيم وللقرى المجاورة يعطوا المواطنين يعني حول الوقاية من الكورونا وكيف المباعدة بين المواطنين، وأي حالة مصابة بسعال نحاول يبعدوها من الأشخاص السليمين، وعلى الإسهالات.
What kind of activities do you do while in your daily work with ADRA?
طبعا أروح الزيارات يعني المنزلية وأخذ المواطن الأطفال من 6 أشهر إلى 57 شهر، والأحال الأطفال يعني لهم في سوء تغذية الحاد الوخيم والحاد المتوسط، يعني الحالة للمرفق الصحي، أيضا الأمهات الحوامل والمرضعات اللي أقل من 23 يعني سنتي يعني عندهم سوء تغذية حالة المرافق الصحية، بالإضافة إلى التوعية على تغذية الأم الحامل والمرضع وتغذية الأطفال والتوعية يعني على كورونا وعلى الإسهالات والأحالة المرافق الصحية يعني.
So what do you do with cases of diarrheal cases that you see at the community level?
يعني أول نقوم بفحص الطفل من خلال يعني مشاهدة عليه علامات الجفاف، ونخبر الأم أنها تعوض الطفل بالسوائل وتستمر بالرضاعة، ثم يعني تحيل يعني الأم لنقل طفلها إلى المرفق الصحي خلال 24 ساعة.
So when you refer to the facilities, how are the patients received when they come to the facility?
يتم استقبال المرضى من خلال العمال الصحيين في المرفق الصحي، ويعني اعطائهم العلاجات المناسبه.
Wonderful. Paul, thank you for that really interesting video. Appreciate the work in community health, and looking forward to hearing from you later with questions. So before we get to the final speaker of our morning, I do want to say again that we are approaching the Q&A section. So if you have any questions, please put them in the chat. So I want to introduce our next speaker. Her name is Zeina Kiragu, and Zeina will be sharing about the CCIH's 30 by 30 Health System Strengthening Initiative. She is a Kenyan pharmacist and public health professional working in the access to medicine space. She is currently a research fellow at the Department of Global Health at Boston University's School of Public Health, and she came to CCIH in 2019 at an annual conference while she was pursuing a master's in public health at Johns Hopkins University. Zeina, welcome.
Thank you. Thank you very much, Rick, for that introduction. Hello all, good morning, good afternoon, and good evening from wherever you are dialing in from. As Rick mentioned, my name is Zeina Kiragu, and today I will be sharing an update on CCIH's 30 by 30 Health System Strengthening Initiative. And 30 by 30 is a CCIH effort to strengthen 30 health systems in which faith-based health services operate by 2030. I will give a brief update, a brief orientation to what 30 by 30 is all about, and then introduce the new commitment makers and give a high-level summary of the commitments we have received thus far. Next slide, please. So this initiative is managed and coordinated by a 4-person team with Mona Bourmet as the program director overseeing the project. We do have a monitoring and evaluation consultant as well, Edwin Sam, and one of our CCIH board of directors, Kate Long, who's also been involved heavily with this initiative, and myself as well. So I am part of the CCIH board of directors, and I am engaged in the operationalization of this initiative in my capacity as a doctoral student at Boston University School of Public Health. Next slide, please. So at the core of the 30 by 30 health initiative is this concept of the health systems commitment, whereby CCIH members, affiliates, and other organizations make a public statement to work in one or more health systems to improve one or more health systems building blocks as defined by the World Health Organization, such as leadership and governance or financing. So the idea is that organizations will in making this commitment will share work that they either have ongoing or that they plan to engage with, and share it in this context of defining their activities as they pertain to the health systems building blocks as defined by the World Health Organization. Through this work, CCIH aims to increase the global attention to the work of faith-based health services, to work alongside faith-based health services to improve resource mobilization and to improve programs and policies, and to gather evidence for stronger health systems for faith-based organizations. Next slide, please. CCIH anticipates that through this process of commitment making, we will be promoting dialogue that facilitates South-to-South learning and also increases the presence and visibility of faith-based organizations in global initiatives, all of which would translate to better capacity among FBOs to deliver quality services and for stronger partnerships amongst FBOs and also across sectors. Additionally, stakeholders will gain a deeper understanding of the value of FBOs, and this work will highlight the urgency to partner with FBOs and invest in FBO work. Next slide, please. So the 30 by 30 initiative was launched 2 years ago at the CCIH annual conference, and that's the conference which I attended as a volunteer back when I was a master's student, and it was received with a lot of excitement, and lots of feedback and input was received from members and organizations, which further informed the initiative and its goals. So a call for the first year of commitments was then put out, and year one commitments were received through 2019 into early 2020. And so the year one commitments were officially launched and published in a report in 2020. In January of this year, we put out a call for year two of commitments. And in the subsequent years, a call for commitments will be made at the start of each year. Next slide, please. So this slide shows the year one commitment makers. We did have 22 commitments submitted in year one, and these were published in a report, as I mentioned, and the report has since been revised to reflect our year two commitment makers, which I will be introducing in the next slide, please. So we are pleased to share with you that we have 10 new commitments in the year two that we received from January to March of this year. And these are from Blessings International, Community Fountain Organization, Christian Health Association of Sierra Leone, who have made a commitment jointly with Healy International Relief Foundation, Kunri Christian Hospital, Ecumenical Pharmaceutical Network, Global Health Action, Kupenda for the Children, National Medical Services Consortium or NMSC, World Hope International, and World Relief. So we do have an exciting addition to the initiative with a diverse set of commitment makers. And if you could progress to the next slide, please. I now will give a brief high-level summary of the commitments that we have received thus far, both year 1 and year 2, and this will give you a taste of where these commitments have been made and what they're focused on strengthening, bearing in mind that a given commitment can be single country or multi-country, and a given commitment can also be focused on one health system strengthening block or area, or multiple health system strengthening blocks or areas. And the detailed activities for each of these commitments are available on the CCIH website in the report that I just mentioned. So thinking about where this work is being done, Sub-Saharan Africa does have the most number of commitments, and this was the case in both year 1 of commitments and year 2, as you can see on the right. We also have 2 of our commitment makers have very broad activities across the globe spanning multiple countries, and we have thus classified them as global commitments. Next slide, please. Looking more closely at the countries where commitments have been made, Kenya is the most popular country in Sub-Saharan Africa, and Haiti is most popular in Latin America and the Caribbean region, and India has the most number of commitments in Asia. Additionally, as you can see on the right, there are countries, there are 14 countries where just one commitment has been made. So it's we have commitments across all world regions, or most world regions, I would say. And if you can progress to the next slide, where we look at the health system strengthening areas. As I mentioned, we have focused the commitment submission process around to make it clearer as to how these commitments are strengthening health systems. We have organized them by health systems block as defined by the World Health Organization. And for the purposes of this initiative, we've also added in community services as a block. So health workforce was the most popular area that commitments have focused on in both year 1 and year 2, so across the board. Although we do see that in year 2 as well, access to essential medicines and supplies is another popular area, and that's likely related to the nature of some of the commitment makers. So we had 2 commitment makers whose main area of focus is pharmaceutical systems. And details of the activities can be found in the report, but I would like to give you a taste of the themes that we've seen in the new set of commitments submitted in year 2. So under health workforce, we are seeing commitments to training to build capacity of health workers in areas that have been identified as lacking, such as WASH in one of our commitments. Leadership and governance is largely focused on developing and or revising policies to facilitate having better systems in place for accountable leadership. And under service delivery, we are seeing organizations commit to undertake needs assessment to identify gaps in service delivery and to address these gaps through training and technical support. We are seeing commitments to reduce stockouts at health facilities, to improve the quality of pharmaceutical services that are delivered at health facilities, and to increase access to clean water supplies. In the community services block, organizations commit to working with churches and community organizations to identify community needs and to implement programs in the community as well. Under health information systems, we are seeing the use of data for decision making as a key theme. So organizations want to increase the use of quality data for decision making and to strengthen capacity for collection of data at health facility level. And lastly, with finances, we are seeing comprehensive evaluations to inform adjustments to financial plans for more cost-effective service delivery. If you can progress to the next slide, please. So this is our timeline. we are currently sharing the new commitments with you at the conference, and we just completed the period of new commitment submissions from January through to April. We will then be entering our data collection and analysis stage, and what this will entail is for our most recent commitment makers, year 2, they will be sharing with us their baseline data, the data on for the indicators they've selected for their given commitments for 1 year prior to the commitment period. So that is the past year, 2020 to 2021. And for our year 1 commitment makers, they will be sharing with us their year 1 data. So we received year 1 baseline data last year. And after this analysis period, we will be having an annual meeting with our commitment makers to share learning, highlights, and to brainstorm on what's working and what is not working, after which there is a reflection and buffer period before the next call for commitments is made in January of 2022. I think that's everything from me. If we go to the next slide, you can see our contact information. Feel free to email us and visit our website if you have questions about the initiative and are interested in submitting a commitment in the coming year, or if you've engaged in similar work around collecting and standardizing efforts across multiple countries and different organizations, and you have any resources that you think may be beneficial for us, please do share. Thank you, and I'll hand it back to you, Rick.
Thank you, Zaina, for that wonderful presentation. Very helpful to see the level of commitments and really just, I think, an incredibly forward-leaning project from CCIH. So that wraps up our speaking section today. We're going to move on to the Q&A section. And just wanted to say, if you have questions, please put them in the chat box, and we're going to start. So let me begin. I think we have several questions already in the queue. So the first one is for Tabani. Vaccine research is an issue due to health facility remoteness and distance to be traveled. This touches on issues of equity and access. What roles besides advocacy can FBOs play to improve this process and effectively engage in those in authority and resources?
I will need that question read again.
Yes. Let me read that question again. Vaccine research is an issue due to health facility remoteness and distance to be traveled. This touches on the issues of equity and access. What roles besides advocacy can FBOs play to improve this process and effectively engage those in authority and resources?
I think this is a difficult question, probably because I'm really trying to unpack it. In my head, it appears to be an upstream question that is really related to, there's a few things that happen upstream, one of them being the vaccine stability issue, meaning that if you don't need cold chain to the last mile, it could help to actually reach communities. Then the other piece is the multi-antigen a type of vaccines, like moving from your pentavalent to your hexavalent, as we'll be doing, or the patches and that kind of thing. So I'm trying to reconcile some of that upstream work and the way the question is framed. I can see how what happens upstream would be helpful for equity and for allowing communities to be able to access vaccines. But there's a few things that have been bundled up in that question. I think that I'm not able to disentangle very well.
Yeah.
I think in the research space, what is important probably is first and foremost for the FPO community to be able to surface some of the barriers that relate to the product itself. And once those are surfaced, then I guess there's the upstream process of saying how can that be responded to with the product itself, and whether it's stability or the number of returns or visits that need to happen. As I said, the hexavalent gives you a killing one bird with with one stone, or killing 2 birds or 6 birds or 6 diseases in that regard with one vaccine, and maybe it helps in that regard. But it was a bit of a tough question in terms of framing. I don't know whether Sarah understood it better than me.
Let me, Tabani, maybe rephrase it a little bit. I think it's the idea of getting vaccines to rural areas. So how I probably misread the very beginning on the research thing. It was reach, I think, rural vaccine reach. So how can FBOs play a role in that?
Well, here I was twisting my head, answering the wrong question. I knew.
I made it extra hard for you.
I knew something wasn't right, and I was trying to be smart. But at least I tried to confess that there is something in the framing that wasn't jiving. In terms of the reach side, I think the first thing that I noted is that the FPOs reach out to these communities with much more than just vaccines. And the communities that we actually serve, they want water and sanitation and hygiene. They want nutrition, and they want other things. And so if we actually bundled that reach with that platform, we are much better placed, because we are reaching with a package of services as opposed to just thinking about the vaccine itself. So I think they have an advantage here of actually having these other set of services, which will in themselves be well received by the communities that we need to reach. So that's a mover's advantage there that is needed, and that we need to tap into.
Wonderful, thank you. The next question, Sarah, unless you wanted to respond to that. Yeah.
No, I mean, just maybe to quickly add, I think there are the complexities with needing a cold chain for these vaccines. But with that aside, I think there are a lot of lessons that can be learned from the delivery of the polio vaccine in many regions of the world, where faith communities were very active in actively going out and delivering vaccines. So that's just a good example to learn from.
Great. So Sarah, the next question is for you. The question is let me make sure I've got my glasses on for this one so I don't misread it. How is faith engagement received within the broader context of the WHO? This work seems so important and can impact other areas beyond humanitarian emergencies. How do groups engage WHO at the country level?
Thanks. Really big question. So I think I don't want to bore people too much with a description of what WHO is, but basically we are what we call a member state driven organization. So we don't do anything that our governments don't tell us to do. So our whole mandate is to serve our ministries of health and our government. Having said that, we have a very clear mechanisms for working with constituents that fall outside of that government sphere. So within WHO, faith partners would fall under the banner of civil society more broadly, which is a bit of a pity because, as everybody knows, civil society is not a homogeneous group, and faith partners have very different things to offer and very different roles that they're playing. Having said that, it's a big organization and it changes slowly, but there is at least what I've witnessed during the COVID pandemic is that there has been an increasing awareness of the need and the value and the imperative to engage more broadly and more meaningfully with different groups. Maybe one small thing to say is we managed to host with Religions for Peace, which is a multi-faith convening body, a high-level dialogue with our Director General on the issue of the faith leaders' role in vaccine equity and access. And we had a 90-minute dialogue between our DG and the faith leaders. And at the end, our DG was very, very direct in saying, we need to engage not only on this subject, but across the entire spectrum of our work, and very specifically on universal health coverage. And so I see a big desire to move this agenda forward, which I find really exciting. But one last point, there was the issue, the question, sorry, I just remembered, how does this trickle down to the country level? It's not always easy because often our country teams are quite stretched, and you have one person who's responsible for several different mandates of work. But I think one way of doing it is through the UN country teams as well, because often you will find that some of our partner organizations like UNICEF has a much stronger footprint in the country. And it's sometimes through these UN country teams that we can really formalize some of the relationships and collaboration. So sorry for the long answer.
Thank you, Sarah. I also want to know, just through my work with the the World Council of Churches, that they are their Health and Healing Office is a kind of a standing member on committees of the WHO. So there are some interaction there as well on that level. So the next question is for Myal. You mentioned a lot of challenges, misunderstandings on vaccines from faith communities. What is the best way, do you see, for churches to address these concerns?
Yeah, well, I think what's interesting is the local church is in the community. And so the local church knows and understands the issues better than even your local country staff or Ministry of Health staff at a headquarters office. And so I think what's really critical in an opportunity like this is for to work closely with the local churches to ensure that they have kind of the scientific and technical knowledge about the truth of these vaccines, but approach how to address, what are some perhaps harmful beliefs at a community level or concerns with, some of the trust issues that I mentioned. And I think that's kind of the two big categories are challenges with trust and challenges with kind of misinformation about some of the medical or technical elements here. And so if you can help the church leaders to buy in and use their word, their position as an opinion leader in the community, I think that's the most critical thing here. And that involves working with the church leaders to help them analyze and understand what's the source of those roadblocks or mental challenges that are kind of or mindsets that are a barrier here.
Great, thanks, Myal. I mean, I know groups have done things. There was a group called CIFA at one point, and IMA was involved with sermon guides and doing outreach through religious leaders on giving, essentially the public health technical information through a set of clear guidelines and sermons that they could then use, building it up in local languages. And I know there's other organizations who've done similar. So I think there's definitely opportunities to shape the messaging on this.
And we've done quite a bit of that actually with COVID, both on prevention and vaccination preparedness with some of those same tools, sermon guides, preparations, kind of equipping the church leaders to know how to speak as a church leader or a faith leader into those issues.
Thank you. The next question is for Barbara. How can Haiti's experience be leveraged for other countries and contexts? Can they use the software or partner with Dalton to do it?
Thank you for that question. I love it. And I'm going to answer, but before I answer that, I wanted to say something that really hit me while Zana was speaking. And I want to say to the CCIH members, I didn't mention it, but we are part of the 30 by 30 and extremely proud to be part of that. And It's a great way for CCIH members to really get involved and have their work be a part of the faith community and be that voice. So I want to encourage people to learn more about what Zana shared and to be a part of it. And then another thing I really wanted to share too is about the CCIH health system strengthening working groups, and particularly the mapping one that I have the privilege of being a part of and co-leading that group. And so I just wanted to do that shout out of like people listening, like and wanting to get involved and learn more ways, please do that. You know, I've had the privilege of serving on the board of directors as well with Zana and Rick. And it's just a great way. CCIH does a great job, I think, of giving ways to make such a big organization and a global organization be practical. And so I just really want to share that real quick and encourage everyone to not feel like CCIH is really big, but you can really get involved at the detail level with the 30 by 30, with the mapping. And I know the whole conference had other examples as well, but I just want to encourage everyone to do that. To get to your question, I'm so glad it was asked. And it's funny, Marie-Claire and I were talking about this when we were off camera and off mic about how we think we've got a system down that can be replicated. And we want to share that with others. So the simple answer, the database, yes, it is shareable. It's set up to be a global data entry. And if you ever go to relinkglobalhealth.org, you'll see how user-friendly it is. It's not a typical database where you have to have a data science experience to know how to use it. It's designed for the public to use. And here in Haiti, it's translatable into French and Haitian Creole. We're working now on adding data for Malawi. And we're definitely interested in talking to others about other countries, and whether it's the data collection process, which was really practical, or if it's the how to implement the projects at a really practical level, we're happy to share anything we've learned and see it replicated.
Great, thank you, Barbara. And then this question is from Marie-Claire. You said that a letter from the Department of Health helped you get participation from local facilities. What recommendation would you have for engaging with departments of health and getting their support for the data mapping work a CCIH member is doing?
Thank you for that question as well. So the Dalton Foundation works in Haiti through the Haiti Health Network, which is registered with in Haiti. So we are registered with MSVP, and then we have our patent, and we are legally working in Haiti. So that gives us the ability to meet with the authorities and ask questions and submit reports, and they know what we're doing. So we are based mostly in the North Department in Cap Haitian, and the director in the North Cap Haitian is very supportive of the work that we do. And through that connection that we have with him, it helps us to have a connection with the other directors in the other departments. In Haiti, a lot of times emails don't work very well, and I find that it is important to schedule in-person meetings with those people and just drop off at their offices and present your work and say, this is what you need, and this is the work that you're doing. If the work that we do, and I think Sarah Hess mentioned in her presentation, that the work that the faith-based organizations do really support the national outcome, the national system. So they see us as great support to the work that they feel that they should have been doing. So they are very open as long as we do things the right way and that we keep them informed. So I would encourage you to have an in-person meeting with your regional healthcare leader, a Ministry of Health representative. And we are also open to receiving emails if there are follow-up questions, or if you need the phone number or an email of one of those people, we would be happy to continue that conversation offline.
Wonderful, thank you, Marie-Claire. The next question is for Paul. Paul, do CHVs work with faith leaders? Are there issues with primarily female cadre working with imams, or how does this actually work?
Well, thank you. For Yemen, it's a bit complex because of the different alienations. But what I would say is that, yes, they work, but indirectly. But basically, for us to gain access, this is the indirect way for us to have access. The first thing is to meet with the influencing groups, the government, and the local authorities. So with the endorsements, with the already endorsements that they have, the community health volunteers are able to work without directly going through them. But also during the time we were identifying the social behavior change messages, remember we are looking for influencers when we are identifying the barriers. So we were directly engaging them, but for the implementation, they're implementing from with the endorsement of the community leaders, even the imams, but there is no direct link. Over to you.
Thank you, Paul. So this question is for Tabani, Sarah, and Myal. We'll never vaccinate everybody, but we can and should make sure testing is available at all critical transmission points, workplaces, public transit, and airports, etc. Are we over-focused on vaccines, or is there a balanced approach needed? So maybe Tabani, you can start, and then Sarah, and then Myal.
Sure. No, thank you very much. I think as a community, we have always been very clear that vaccines are not a panacea. They are part of the toolbox. And they have got to be used as best as they can. If in the set of defenses that we have, vaccine can play their contribution, it must be played to its fullest extent. But there is a set of complementarities that are needed. I think you'll be aware of the ACT, the accelerator, the access to COVID and therapeutics pillars that were set by the WHO DG. And the therapeutics piece is another important piece that is important in that space. But having said that, I think we will always argue that prevention is better than cure. You don't need to be waiting for therapeutics if the vaccines can stop you from actually being in the hospital. So I think it's a set of tools box. It's not the only one, and it must be recognized as such.
Sarah?
Sure, no, not much more to add. Yes, a balanced approach is definitely needed, not least because it's going to take a long time before vaccines reach everyone everywhere. When you look at the recommendations that WHO put out for prioritization of vaccines, the public health objective at this stage is really to reduce mortality and morbidity and to reduce the pressure on the health system. And so while we vaccinate those who are vulnerable, the health workers, those at risk of more severe disease, we need to keep in mind that there is a responsibility among the rest of us to not to not add to that pressure on the health system as well. And so ensuring that we maintain these public health and social measures that everybody knows so well is critically important everywhere. So fully agree that a balanced approach is necessary, and at this stage to behave like the vaccine is going to solve everything immediately is really quite dangerous.
Yeah, I'm not sure there's much I can add. I think I really affirm the importance of prevention and this idea of a balanced approach. I think what I would add is really it is essential to consider equity and the decisions that go along with that as well, and not to exclude the most vulnerable because they may be hard to reach in some of those situations, and how to balance that really is a critical question for us. And I think it comes back to what we've been talking about quite a bit today, which is the availability of what may be perceived as non-traditional resources, which is engaging the church and other community actors to reach people, is really something that we need to also make sure that we fully consider options before we roll out vaccination.
Well, thank you, thank you. So I think we have time. There's one last question, and this is for Zaina. So Zaina, the question is from someone, I think in Guatemala. How do we become part of the 3030 initiative in Guatemala?
That's a great question. As I mentioned, we do make a call for commitments at the start of each year. This is a project that will run through until 2030. So what I would advise, if you're interested in joining and making a commitment to share the work that your organization is involved in, is you can email us to express your interest now, and we would send you a personal reminder next year when the call for commitments is made. If you are a CCIH member, that call is put out to all CCIH member organizations, so you will receive a notice that we are accepting submission of new commitments. But you can go ahead and email us now to express interest.
Wonderful.
Thank you.
Thank you, Zaina. So that concludes the Q&A section this morning. I wanted to thank all the speakers again for just the amazing insight that you've provided, the stories, the approaches. Really have appreciated everyone. And again, thank you for your time. And I'm sure we will all, especially people on the line today, will want to reach out and talk to you more. So at this moment, I'm going to again thank everyone and then transition over to Mona.
Hi, did it work? I was trying to unmute myself. Thank you so much to Rick and to all of our speakers. It's been a pleasure learning from you this morning. Thank you for joining us from so many different parts of the world. And thank you to Rick for facilitating us through everything. I think there are so many aspects of health system strengthening that we did not get to, but there were many other days of the conference where we focused on different pieces of health system strengthening, whether it's community, technology is part of health system strengthening, our learning. There's so many different aspects, but really thankful for what we were able to focus on for today. Now, at an in-person conference, we would be together for hallway discussions and talking over meals, all those fun things. And unfortunately, we don't have that ability, but our way of trying to have networking and discussion is we'll have breakout rooms soon. So we'll have breakout rooms for about 40 minutes, and then we'll come back for a closing. But before we transition to breakout rooms, we're going to ask you all if you'd be willing to turn on your cameras and just wave at everyone and say hi. We know during this time of the conference, sometimes it's easier to keep your camera off for bandwidth and all of those things, but if you could just wave at each other. I love seeing people's faces. I see Mark in Ireland. Let's see, who else do I see? Mark in North Dakota, Douglas in Massachusetts, George in Kenya, Chris in Bangladesh. Who else am I seeing? I'm gonna flip screens. Henry in North Carolina, Yoram in Zambia. Who else do I see? Sorry, Caitlin in Seattle, Emily in North Carolina. I don't know where everyone lives. Nancy in Bangladesh, Claire in Kenya. Oh, I love seeing everyone's faces. This is fun. Hi, Caroline. Hi, Wilma.
David from India.
Ah, yes, hello. So this is fun.
Yeah,
so
hello.
thank you all for doing
Yeah.
that. I just think it's fun to see everyone.